Good
morning or afternoon or whatever it is there.
Whatever time zone you're in.
Right. How's everybody there? It'd be nice to see some faces. There's somebody I recognize.
Hi, Ed. How are you? Hi, Paul.
Hey, Patricia.
Hi, Patricia.
Our esteemed guest.
Hello, everyone.
Hi, Ma.
Hi, Ma. Where are the others? Come on, open up your cameras. Show your faces.
Good afternoon, everyone.
Hey, Colin. What time is it? What time is it? 1 minute to go.
1 minute to.
Where's Caleb? You there?
Yep, I'm here.
Okay. All right, so you're running the slides, I understand. Are you running the slides for everybody, Caleb?
No, just for myself, and each trainee can present their own slides. I'll take mine off.
Okay, but you've got mine, is that right? Or do I need to get mine?
No, I have all the slides for you. You just have
Okay,
to tell me
cool.
to move forward. Yep.
For the incompetent host, right? Okay, give you another 30 seconds because it's 10 o'clock and we have a tight schedule here. Actually, not so tight. Okay. All right, so I'm going to get underway. I don't know what's on this slide, so you have to remind me, Colin. What's the next slide? Oh, there we go. How about that? So I'm Ed Conway. I'm the interim director of the Center for Blood Research, professor of medicine at UBC. I've long been involved in CanVector, and Paul Kim and I are co-directing the scientific session. So say hi, Paul. Paul says hi.
Hi, everyone.
All right. So it's really an honor and a pleasure to host this mini research event presented by our esteemed young scientists who are supported in various ways by CanVector right across the country. And so we're going to hear from each of them with short presentations of 5 to 7 minutes each. We'll have time for questions. So I encourage everybody, all those faces, to light up and ask questions for 2 or 3 minutes to keep all these people on their toes. Don't count on me alone. All right. And so we will get underway, and then we will have a keynote presentation from our famed Patricia Lau. And Paul will do the intros then. And then we will have a trainee award for best presentation. And I understand there's a scoring method. So next slide. Oh, but let me not forget, first of all, that these presentations are taking place across the country in various First Nations, Indigenous lands, in which we all appreciate the opportunity to do so. And then, of course, we thank all our partners who have provided support for CanVector and for you personally, all of you trainees. So never forget to thank them. All right, next slide, please. Oh, so we're going to do the trainee presentations. Are there instructions on how to give the scoring? Yes, there are. So you can vote at slido.com with that number, 211, I'm going to write it down, 211-3629, or click on the link in the chat. Is it in the chat?
I'm going to put this all in the chat. So
Okay.
yeah,
okay.
You can just rank the applicants throughout the competition. So, but I will, again, I'll put this in the chat.
Okay, got it. All right, you guys know the route for that. Okay, so are we going to start the first presentation? Yes, we are. So Lisa Yamura, a PhD candidate from the University of Calgary, supervised by Dr. Schneider, novel multimodal approach to quantifying hypercoagulability and platelet activity in patients with metastatic bone disease after orthopedic surgery. So Lisa, take it away.
Thanks so much for the intro, Dr. Conway. I'm just going to request to share my slides.
There you go.
You guys see?
That's perfect.
Okay,
But just put it in presentation mode. Go ahead.
perfect.
Good.
Right. Just going to minimize you guys over here. So I am from Dr. Schneider's lab, and I'm going to present today on the platelet contribution to hypercoagulability in patients with metastatic bone disease who have had orthopedic surgery. So firstly, metastatic bone disease occurs when patients have aggressive cancer that spreads to the bone, and it increases susceptibility for patients to experience fractures, which commonly require orthopedic surgery to treat. Now, unfortunately, by having malignancy and undergoing orthopedic surgery, patients are at risk for blood clotting complications known as venous thromboembolism. This includes blood clot development in the legs, known as deep vein thrombosis, that can migrate to the lungs and become pulmonary embolism. Now, after orthopedic surgery, patients are typically prescribed 4 weeks of anticoagulant medication to prevent these blood clots, but these guidelines are based on patients without cancer and don't take into account that increased risk for blood clotting complications. So given this limitation in prescription guidelines and increased risk for patients to experience VT complications, due to a lack of understanding of hypercoagulability, we wanted to investigate hypercoagulability a little bit more by looking at the extent and duration of hypercoagulability following orthopedic surgery, as well as looking at how platelets contribute to this hypercoagulability, both in terms of platelet receptor pathway activation that promotes platelets to aggregate together, as well as platelet surface membrane activity, which can indicate whether platelets are activated and in a procoagulant state that contributes to blood clot formation. So for our first aim, to identify the extent and duration of hypercoagulability, we use thromboelastography, or TAG. It's a point of care test in which we take a small sample of blood, we put it into a cartridge, and we're able to put the cartridge into the machine to run our test. We have 2 different types of cartridges that we can use to do 2 different types of testing with TAG. What happens is the machine will generate a clot formation inside the machine, and there's a key parameter, which is clot strength, which is shown by maximal amplitude, or MA, measured in millimeters. Previous research in orthopedic surgery has shown that patients who have maximal amplitude of 65 millimeters or greater are at nearly 4-fold increased risk for the development of blood clotting complications. So we hypothesized that using this threshold to define hypercoagulability, and because of patients having malignancy, they would still be hypercoagulable more than 4 weeks postoperatively. So their hypercoagulability would continue after they had completed their medication to prevent blood clots. Next, we wanted to look at platelet receptor pathway hyperactivity. So we use the second type of platelet of TAG cartridge, which is called platelet mapping analysis. There are 2 different types of stimulants that we can use, arachidonic acid and adenosine diphosphate. And these can stimulate clot formation when they bind the agonist binds the receptor, stimulates the platelets to aggregate together to form a clot. Previous research has shown that maximal amplitude of 55 millimeters or greater is associated with platelet hyperactivity. So we hypothesized that patients who developed VT complications would demonstrate that increased platelet hyperactivity. Next, we wanted to look at platelet membrane activity. So we used fluorescent imaging to do that. We used 4 different types of antibodies to label the platelet. Alpha-2 beta-1 is a collagen receptor on the platelet, which we use to locate the platelet in our imaging. P-selectin is exposed on the platelet when the platelet becomes activated. So we were able to label that as well. We were also interested in looking at phosphatidylserine exposed on the membrane, and that occurs when platelets are in a procoagulant state. Annexin 5 is able to bind to phosphatidylserine, so we use that label to indicate that phosphatidylserine was there. Next, when platelets are procoagulant, they generate a lot of thrombin, which is really important for the clotting process, so we labeled that as well. So using these fluorescent labels, we hypothesized that in tandem with our increased and prolonged hypercoagulability, we would see prolonged platelet membrane activity as well. So for all of our testing, we required blood samples. We collected several times over a 3-month postoperative period. We also performed an ultrasound on patients on postoperative day 3 because they're at such high risk for blood clotting complications. And by capturing some data at 6 weeks and 3 months post-op, we're able to see what happens to patients after they've completed their anticoagulant medication in terms of hypercoagulability, platelet receptor activity, and membrane activity as well. So we enrolled adult patients who had orthopedic surgery because of having metastatic bone disease. We excluded patients who had primary bone tumors, anyone who was pregnant, and anyone who already was being treated for an acute blood clotting complication. I'm showing data here from a subgroup of our patients. They're 35. The median age was 70 and 60% of our patients were female. Predominantly in our group, nearly a third had primary breast cancer. And we had a VTE rate of 14.3% with 5 patients. 4 patients had deep vein thrombosis found on our screening ultrasound, and 1 patient developed pulmonary embolism. So we looked at these 2 groups, patients who had VTE and patients who did not, and we found that patients who had VTE were more hypercoagulable on average than those who did not. We also saw that postoperative hypercoagulability was prolonged. At 6 weeks post-op, the mean MA value was above 65 millimeters. Next, we found that this hypercoagulability was platelet mediated. We saw that patients who developed VTE complications demonstrated increased adenosine diphosphate and arachidonic acid platelet receptor pathway stimulation. And we saw that at 6 weeks post-op in patients who did not develop VTE, they were still above that 55 millimeter threshold. We saw that adenosine diphosphate platelet receptor hyperactivity was most pronounced in both groups, whether patients had VTE or not. Next, when we looked at our platelet membrane activation, remember we have alpha-2 beta-1 to identify our platelet in imaging. We have p-selectin to look at platelet activity, and we have annexin-5 and thrombin to show platelet procoagulation. We saw that at the beginning, when we merged all of these platelets, these probes together, we were able to see that procoagulation and platelet activation was attenuated acutely after surgery. However, there was a big increase that we can see here shown visually and also quantified here. There was an increase in platelet activation that was quite significant in all of these fluorescent antibodies at 2 weeks, 6 weeks, and 3 months post-op. So this shows us that hypercoagulability was prolonged, it was platelet mediated. We saw that there was an increased pathway activation of the adenosine diphosphate and arachidonic acid pathways in patients who developed complications. But regardless, we saw that platelet membrane activity was increased. We saw that it was well controlled with the low molecular weight heparin that patients were taking, that anticoagulant during the acute postoperative phase. But we saw that platelet activity, membrane activity really took off after 2 weeks postoperatively. So this suggests that future investigation would be worthwhile potentially into drugs that target the adenosine diphosphate pathway like clopidogrel or the arachidonic acid pathway like aspirin. Potentially even novel therapies that target platelet procoagulation could be interesting to look into as well. And I just wanted to thank some CAN Vector members, my supervisor, Dr. Schneider, committee member, Dr. Skeeth, and Dr. Gbani, who's been super helpful with the imaging analysis, as well as our orthopedic trauma research team. And happy to answer any questions.
So any questions? Or while you're thinking, oh, Maha, did you have a question? I can see you're nodding.
Yes.
Go ahead, go.
Actually, I was going to raise my hand right now. So great work, Lisa. I love TEG and I know it's useful. I'm one of the people who believe in it. My question to you, a couple of quick questions. The first is, so do you think TEG can prospectively assess people and predict the ones who are going to develop thrombosis or not?
Yes, I think that it definitely has very useful applications, but I think that because cancer is so heterogeneous in terms of how people are going to be to respond, I think we do need to take that into consideration. So I would be interested to see if we can use TEG to develop potentially guidelines specifically for patients who have liver dysfunction, like a hepatic cancer. They would have differences in terms of their clotting factors, in terms of, so they might have different response. Patients with low platelet count because of cancer as well. Potentially, if we're looking at maximal amplitude, for example, we might see a lower maximal amplitude, but they could still be at risk for thrombosis. So I think definite utility, but we just need to be careful about which patients we're looking at.
Okay, thank you. And my second question is, p-selectin and annexin-5 are both markers of platelet activation. And you mentioned always platelet activation in association with p-selectin, but you mentioned the term platelet procoagulant activity when you talked about annexin-5. What's the difference between activation and procoagulant activity, if there's any?
So platelet activation is just when platelets are stimulated to become active. I would say that platelet procoagulation happens a little bit later. Not every activated platelet is going to become procoagulant. Platelet procoagulation is also characterized by having membrane ballooning and an influx of fluid into the cell that happens. So there are some irreversible physical changes. So I would say that platelets that are procoagulant have become activated, but not all activated platelets will become procoagulant.
Good answer, although I think the area is debatable, but thank you.
Lisa, I'm just curious, what kind of surgeries are these? They're having orthopedic surgery. Are they above knee, below knee? Are these fractured long bones? Is there a variety?
So there is a little bit of a variety. It's predominantly so it's long bones, predominantly the femur and the hip. We did have a couple patients who did have humerus surgery.
And any idea why you're seeing things happening 2 weeks plus later after the event? Like, why is it taking so long to see these things? I mean, platelets turn over so fast. Why aren't we seeing much more acute changes?
That is a very interesting comment. We did have all of our VT complications occurred within the first week postoperatively. So we did see a lot of VT complications then. I did not have any VT complications that happened after the 2 weeks postoperatively. So it was really picked up on in terms of platelet membrane activity that happened in the late phase after 2 weeks post-op. I would speculate potentially that due to inflammation and wound healing, those cytokines involved in inflammation could have potentially precipitated maybe that continued persistent platelet membrane activation.
Are they in, I'll let you go in a sec, Paul. Are they these patients in hospital throughout the course, or are they at home?
So patients are typically discharged by post-op day 5, sometimes a little bit earlier. So most of them are mobilizing, they're ambulating. We are able to follow up with them in the CAS clinic when they return to see their orthopedic surgeon at like 2 weeks and all the way up to 3 months post-op. But the majority of them were discharged post-op day 5.
Okay, Paul, did you have a question?
Yeah, I just want to mention we're really encouraging the trainees to speak up and ask questions. Like, that's the whole purpose of these informal, if you will, presentation. Having said that, since there are no hands up at this moment, I just wanted to ask you one quick question. In that example of the imaging that you showed and the time courses of them, I couldn't help but notice that at least in that one example, the expression of the phosphatidylserine did not directly correlate with thrombin generation or presence, if you will. I wondered if you had noted that, or if you saw that with other patient samples as well. It's interesting because you would always think those are going hand in hand, right? So this could be the distinction too, in that somehow there's a disconnect between not necessarily a PS exposure to hyperthrombotic coagulant state.
Yes, that's a great comment and a keen observation. I wonder if it's potentially because I should have mentioned this was a subgroup of those 35 patients. So that was 5 patients. They had primary colorectal cancer. So for our imaging, we did try to kind of keep the cancer groups together. And we have a separate breast cancer cohort that we're working on right now for publication. But it was colorectal cancer. So I'm wondering if maybe the pathophysiology of the colorectal cancer has some differences. And maybe when we look at our breast cancer group, we can see if there's a difference in terms of that phosphatidylserine, annexin 5, and the thrombin generation in that group as well.
Okay, Lisa, thank you very much. I think we'll move on to the next speaker. And
thank you.
Thanks. Is Sean Carlin. And just a warning to all your trainees, further to Paul's comment, I may use my executive privileges here and ask you to ask a question. So be ready.
Was it okay?
It was so good.
It was so good. They're talking.
Was it?
Yeah.
Okay, maybe you should turn off your mic, Lisa. All right. And all right, who's on? Sean?
I am up.
There you are.
I'm
okay,
ready.
You're on. Go for it.
Perfect. I'm going to be presenting for hyperglycemia-induced hypercoagulability in a fit model of sepsis. So why the primary question that was the impetus for this research was independently hyperglycemia carries several risk factors for VTE, including just a general increase in propensity for venous thromboembolism, an increased risk for infection, an increased risk in developing atherosclerosis, general increase in mortality and morbidity, and additionally, individually, sepsis in of itself, which is a very highly interested area in our lab, also carries its own risks for venothromboembolism, including increased consumption of platelets, decrease of anticoagulation proteins, and a general increase in mortality and morbidity. So then that led us to the question of how does the combination of both hyperglycemia and sepsis influence coagulability in sepsis. So our specific aim was to investigate the impact of hyperglycemia on coagulation and inflammation in a mouse model of FIB. Particularly looking at, for coagulation, we're going to be looking at thrombin antithrombin complex and protein C, specifically for, protein C is the measurement of our microvascular coagulability, and thrombin antithrombin is somewhat more of our general coagulability. Whereas for inflammation markers, we're looking at pro-inflammatory markers for IL-6 and anti-inflammatory IL-10. So how do we go about inducing hyperglycemia and sepsis in a combined model? So to do that, to influence hyperglycemia or impact it, we injected a drug called streptozotocin over a course of a 3-week period that selectively destroys the beta islets of the pancreas. We then allowed those mice to age from age 7, which is the last week that they received streptozotocin, up to ages 11 to 12 weeks. At which point we injected a house-made fecal slurry from rats into the peritoneal cavity, which then induces sepsis in these mice. For this method, we did an initial 8-hour exposure, basically a hyperacute phase of sepsis, following which we culled the mice, collected plasma and organs, and then measured our inflammatory and coagulability markers. What we saw was in our hyperglycemic mice, we saw a significant decrease in blood glucose over a 4-hour period from 4 hours to 8 hours after exposure to FIB, indicating that there's some sort of overconsumption of glucose happening that didn't occur in our normal glycemic mice as significantly. Looking at our inflammatory markers, we see an expected increase in IL-6 in our mice, significantly in our normal glycemic mice, and an increase in both our normal glycemic and hyperglycemic mice in our anti-inflammatory markers, indicating that there's obviously the sepsis has taken hold and there's a response from the body or from the mouse to sepsis. And how does it affect our coagulation? We see that in our hyperglycemic mice, there's a significant decrease in protein C, accompanied with a significant increase in thrombin antithrombin, which we did not observe in our normal glycemic mice. Interesting. So taking this, this observed increase in coagulability, specifically in the microvasculature, we then extended this study to a 48-hour exposure. So we followed through with the same streptozotocin injections followed by the fecal slurry, but this time, rather than a hyperacute model, we looked at an acute model of 48 hours of exposure to see if this trend continues on or if there's some sort of alteration to the mouse coagulability. Interestingly, we saw that there was a very minimal difference in survival outcomes in our mice, with our hyperglycemic mice having around 50% survival and the normal glycemic mice being around 45 to 30. Interestingly, we observed that in our mice, as expected, the mice that perished during our studies reached significantly lower blood glucose levels, dipping into the single digits, specifically in our hyperglycemic mice, whereas those that survived, they saw the same precipitous drop in the first 8 hours, but then that blood glucose level appears to plateau out to 24 hours, and then subsequently increase by the end of the study. Interestingly, we still see that significant increase in both inflammatory and anti-inflammatory markers as expected in sepsis. But interestingly, this time we didn't see the change in protein C and thrombin antithrombin that we observed in our 8-hour study, indicating that there's some sort of alteration occurring to the coagulability of these mice as their exposure to sepsis prolongs. In conclusion, we observed that within that first 8 hours of FIP exposure, our mice display a very procoagulant phenotype that's not observed in normal glycemic mice. And there's a modest survival benefit in longer-term FIP exposures for mice with hyperglycemia, indicating that there may be some sort of marker that we haven't observed that is increasing the survival for these mice. In addition, this could be used as preliminary information for providing a potential advantage for the early administration of anticoagulants in hyperglycemic patients with sepsis because of their higher propensity for coagulation that we didn't see in normal glycemic mice. Future directions, we did collect organs, and to further understand how the coagulability of these mice are changing, we're going to be doing fibrin staining on the organs to see if there's specific organs that are more likely to have coagulation. Additionally, there's a certain set of proteins called advanced glycation end products that are basically a non-enzymatic reaction between proteins and sugars that covalently bond and change their functionality. And we want to see how those proteins affect the prothrombotic and pro-inflammatory markers that we've seen in our hyperglycemic mice. Additionally, using a genetic model of hyperglycemia rather than a drug model to see if we can more accurately represent type 1 diabetes in this kind of experiment. All in all, I'd like to just thank my supervisor, Patricia Liao, all my lab members, my committee members, and then our fellow collaborators on this project.
Thanks, Sean.
Thank you.
Apologies for not giving you a fair introduction there, but
that's more than okay.
All right. Questions? Well, we have lots of sepsis people down there. So can you just comment on the use of the model? Is this, it's a fairly acute model, this model.
Yes.
It's it's a very acute model, as a matter of fact. So do you think you'll see the same effects if you used a more chronic high-fat diet-induced model or something else like that?
Yeah, so I think that you definitely see a different response. What you would benefit from using a more chronic model is you'd be able to observe the functional damage on the organs more, especially because it would be more accurately representative of longer-term sepsis outcomes. What I think you'd see is a lot more organ damage that would lead to maybe a later stage of mortality.
Do we have anybody?
I think there's two.
I can ask a question.
Please.
So I was wondering if you separated out your data based on sex at all, and if there's any difference in survival.
Yeah, so let me see if it'll show up. I have some survival data. I have my survival data separated out by biological sex. We didn't see any major differences can you see that? I know it's probably not the greatest, but you can, we didn't see any major significant differences in survival outcomes based on biological sex, which in turn, we didn't necessarily feel it was necessary to observe if there were significant differences in our coagulability markers or inflammatory markers. We do see that like our hyperglycemic mice in red and in blue here do better than their normal glycemic counterparts, but that's the same thing that we observed in our hyperglycemic or in the combined data.
But it's certainly a good question, because in most studies in mice in particular, there are sex-dependent differences, not both in thrombosis, but as well as in insulin sensitivity studies.
Yeah, which was something that we did. I did somewhat observe is even in our the formation with the streptozotus and injections, we do actually observe that sometimes the females are somewhat resistant to the streptozotus injections, and they require like an extra week of the injections to ensure that they're developing the hyperglycemia.
You're muted, Ed.
Okay, Kretz, sorry, your hand.
Wait, before Colin goes, I think Erblin had his hand up.
Oh, okay.
I actually had the exact same question as Veronica, so.
I see. How convenient.
Okay,
right.
Dr. Colin,
Go ahead,
go for it.
All right, I do not have the same question.
Thank you.
I'm curious about the what you think the mechanism of this prolonged survival in the hyperglycemic mice could be. I mean, this may or may not be real, and I guess you'll do more studies to confirm whether this is a statistically significant survival benefit. I'm curious, do you think that this is related to some metabolic capacity that these hyperglycemic have advantage of over normal glycemic mice that just allow them to withstand the systemic challenge of sepsis? Like, just in general, what are your thoughts?
Yeah, so I have another figure here that it's a little, some of them are overlapped, but basically this is looking at like the percent body change in body weight of our hyperglycemic versus our normal glycemic mice in conjunction with my survival data. And we see that my hyperglycemic mice stop losing weight as quickly as the normal glycemic mice at around 28 hours, which is when the normal glycemic mice continue to perish after 28 hours, and our normal glycemic mice seem to stop. So there may be some sort of metabolic change that's occurring within this time period that's helping the hyperglycemic mice, whether that be the lower circulating glucose is impairing the microorganisms within the bloodstream that are causing the sepsis, or is it the difference in body fat? Like there's no glucose stores in our hyperglycemic mice or lower glucose stores compared to the normal glycemic mice, and is that the crux of the issue? But at this stage, this is the most that I have to answer that it's maybe a metabolic difference at the later stages.
Okay, thank you.
Okay, before we wrap up, just a quick one from Dr. Othman. Why did you choose TAT and protein C in particular?
So for TAT and protein C, so we chose protein C because specifically with a hyperglycemic model, they're definitely more there's a propensity to have that microvascular damage, specifically like if you think in the kidneys and those glomeruli, just due to that increased pressure. So I wanted to observe whether or not the decrease in protein C was exacerbated in a septic model. And then we chose thrombin antithrombin, mostly just so it was a model that we've already used in our lab. And I felt that it was a pretty decent marker for diffuse coagulation in the body. We don't get to see a specific area. So I think that's mostly why we chose TAT and protein C.
Good. Okay, thank you very much, Sean.
Thank you.
All right, our next speaker, Ashley Clark, a candidate, master's candidate, University of Calgary, Dr. Schneider's group investigating the duration. Oh, I lost that one. Okay, we lost the slides. But Ashley, you can go.
Okay, let's start with, can everyone hear me okay?
We can hear you, but we don't have any
Perfect.
slides.
All right, let me just screen share. Here we go, 1 second. Sharing. This.
But
I'll let you finish the title.
Yeah.
I think someone is still talking.
Everybody, please turn off your mics if you're not actually talking to us.
Okay,
right.
perfect.
Okay, Ashley, I'll let you finish up.
Okay, perfect. I'll take it over from here. All right, so thank you for the introduction. And thank you all for showing interest in my project and for being here today to listen to me talk about investigating the duration of hypercoagulability in patients with non-operatively managed pelvic and acetabular fractures. So this is a pilot case-controlled cohort and a side passion project to my master's thesis that was actually kindly supported by CanVector. So thank you and a shout out. And I'm going to share why this is important and some of our initial preliminary results. Okay, so it's known that orthopedic fractures are an independent risk factor for the development of venous thromboembolism or VTE. And the underlying physiology that drives the formation of thrombosis is explained through Virchow's triad. There we go, which we're all aware of, I'm sure. And it includes that hypercoagulable state, venous stasis, and endothelial injury, all of which are present following an orthopedic trauma or those broken bones. And it varies by the degree of an injury. So, for instance, pelvic and acetabular fractures. These are very large fractures, and they often have significant associated soft tissue injury. So we're talking about the pelvic ring and your hip socket. These are big injuries, lots of associated soft tissue damage. So those, check off those boxes of Virchow's triad that I just outlined. And these pelvic and acetabular fractures can sometimes be treated surgically if they are requiring that, but they can also be managed non-operatively. It's kind of that Hippocrates oath with do no harm. If it can be managed without having to have surgery, then we go down that route. Now, however, those who do require surgery have that secondary insult of the surgery itself, which further, elevates our elements in Virchow's triad. And those amplified elements and that surgical population is what I was looking at in my main master's project. So for this, I was interested in looking at the non-op. And the reason why is that out of all orthopedic fractures, pelvic and acetabular fractures have some of the highest VTE rates. And after surgery, we have a 12% rate despite thromboprophylaxis use. And that was seen in this large prospective study out of Europe. However, VTE rates of smaller studies for PA fractures have been shown to be as high as 35% despite thromboprophylaxis use. And that was my master's project. And in that, I had a 23% VTE rate in my cohort. And I had 71% PE and 29% with proximal DVT. So you can see this is a quite significant issue. And that's for those surgically treated patients. Now, all these statistics I've talked about are those surgically managed PA patients. And that might make you go, well, what about the non-operative managed patients? And there's a lot of uncertainty about what's the best course for thromboprophylaxis treatment and duration for those patients. So often non-operative managed patients are included with the surgically treated PA patients within the literature. And both populations are said to have high VTE rates. Now, there are no clear guidelines to help the physicians regarding the ideal thromboprophylaxis use and duration for these non-op patients. The current practice of orthopedic surgeons typically consists of them prescribing low molecular weight heparin while they're in hospital and then discontinuing that following their discharge. However, the sentiment of those physicians wanting more evidence to guide their treatment and the optimal type and duration is echoed by both the surgeons at our site alongside the results from an Orthopedic Trauma Association survey that was performed. And I have highlighted it here. And I think their conclusion really does speak for itself, saying that the surgeons want more evidence to guide their prophylaxis prescription for the optimal treatment of their patients. Fair enough, right? So part of this was addressed in this randomized control study. And I included this as a further example as to what I'm talking about with regards to the non-op PA patients and our operative patients. So highlighted in their method section, it says they included any operative extremity fracture or any pelvis and acetabular fracture. So that includes our non-op PA patients. And the results of the study were actually published at the beginning of this year. And this is it. And essentially, it helps to provide some evidence regarding what type of medication is appropriate for this cohort. However, our optimal duration is still unknown. And that's what leads us and me to be curious and want to investigate the duration of hypercoagulability for this population in particular, which we have done through the use of thromboelastography. So you already kind of heard a little bit about this thanks to Lisa. We're from the same lab, different, obviously, populations, but the gist of thromboelastography, or TEG, because that's easier to say, it's a whole blood point-of-care test, and it measures parameters of coagulation, and one of which is called maximal amplitude, or MA. And it essentially measures the strength of a clot and can be used to quantify hypercoagulability, with values greater than or equal to 65 millimeters being associated with a 3.7-fold increased risk for in-hospital VTE for trauma patients, like these pelvic and acetabular fracture patients. Now, the impetus for the study, for this pilot study, it was to investigate the duration of hypercoagulability in patients with non-operatively managed pelvic and acetabular fractures, and to determine the feasibility of us continuing this investigation to see if there are potential differences between the operative and the non-operative patients, to provide evidence to inform clinical guidelines regarding the duration of thromboprophylaxis for this population. Now, utilizing our TEG analysis, we aim to observe the duration of hypercoagulability for those non-op PA patients. And then we wanted to compare the hypercoagulability profiles between age, sex, and injury matched pelvic and acetabular fractures. So when I was talking before about my surgically treated ones from my thesis cohort, we're matching those age, sex, and injury to these non-ops that we are recruiting consecutively. So getting right into that. This is a prospective cohort study of skeletally mature adults with radiographically diagnosed pelvic or acetabular fractures who are admitted to Foothills Medical Center here in Calgary. And listed are our exclusion criteria, essentially things that would also impact our TEG results, such as malignancy, which we already kind of chatted about, such as history of VTE, having a known clotting or bleeding disorder. So, things that we kind of all in this realm are aware of. Now, our collaborative team agreed upon standardized thromboprophylaxis with low molecular weight heparin for 28 days post-operatively for those operative patients. And then what we did for non-operative is, as the current standard of care and guidelines are, say up to the discretion of the physician for those non-op patients. So that is exactly what we did. And then here I've outlined our time points for our TEG analysis when we actually got those blood samples. Starting upon admission after a fracture, after a PA fracture, and then post-operative for those surgical patients on day 1 and 3, and then at 2 weeks after surgery, 4 and 6 weeks after surgery. And then we tried our best to pair those the same kind of time frame for our non-operative patients. Now, obviously, they're not having surgery. So we looked at post-fracture day 1. So they still come into the hospital. Typically, you get your injury, you go into the hospital right away because you're like, ow, that hurts. And then they get the x-rays, and then we do the next day is our post-fracture day 1, and then we do post-fracture day 3. So we paired those along with post-op day 1 and post-op day 3, and then still 2, 4, and 6 weeks. Now, we use descriptive statistics, 2 sample t-tests, Wilcox and rank sum for comparison. Now, our initial results, what are we seeing so far? We have 12 patients, so 6 in our operative, 6 in our non-op, we paired them. We actually had 4 females in both groups. So that was a little bit of a shock, I guess, if you will, for us, because in my thesis cohort, there were only 8 females total. So we were seeing a little bit more of those non-op patients being female. And then we had an age of 53, so pretty middle age. Fracture type, we had an even split between pelvic, so 3 pelvic for non-op, 3 pelvic for op, 3 for non-op, you know, you get it. So half and half, which is nice to be able to compare. Then out of our non-operative patients, 5 of them received thromboprophylaxis while in hospital. 1 patient actually did not. The physician just decided not to provide anything because they had ongoing issues with bleeding. Fair enough. So this is a visual representation of what we're seeing with our MA values. It shows us our mean plus or minus 1 standard deviation for the MA, comparing the operative and the non-operative. So operative here in orange and non-op in our black. And all patients, you can see, demonstrate a peak MA at 2 weeks after their injury, regardless of if they're op or non-op. And there was no statistically significant difference in MA at any of the time points between the groups, suggesting a very similar post-fracture hypercoagulability. You can see the general trend is following, and that there's really no difference. That really starts to highlight the fact that maybe this is worth continuing to investigate, because maybe these should be more standardized with a thromboprophylaxis. Essentially, because we saw that similar hypercoagulability response to injury and increased VTE risk for all of our PA patients, regardless if they're treated operative or non-op, we believe that this supports further investigation to provide thromboprophylaxis recommendations for patients with PA fractures who are treated non-operatively. Here are some of my references, and then thank you so much, my supervisor, Dr. Prism Schneider, committee members, especially Dr. Leslie Skeeth, who is a CanVector member, orthopedic research team, and our trauma service, and everyone here. Honestly, thank you, CanVector, as well. So, any questions?
Thanks, Ashley. I'm sure there'll be lots of questions. Trainees, any questions? We do. Nicole.
Yeah, sorry, I couldn't figure out how to raise my hand.
Okay, I'm watching you.
Okay, I have a question about how you were recruiting patients who weren't getting surgery. So I imagine that they were presenting to the emergency department. Were you actually recruiting them there during that visit? And when did you actually collect the blood? Like, did they have to come back? Just wondering all about that.
Yeah, the logistics behind it, totally fair. And thank you for the question. So this was a little bit trickier for the non-op patients because they didn't come through our surgical rounds, which is where we usually get our operative patients. So I really had to get a hold of the residents and engage them in our research. So that's why they specifically got the shout out, the Foothills service, because honestly, they would let me know if there's an eligible patient who's probably not going to be going for surgery, but has this fracture type in the emergency department. And then I would get the text message, hey, there's a potential patient, come on in. So then I'd hop on in, and then I would go and I'd search them up and then go to the emergency department and recruit them. So I either recruited them in the emergency department, or if they were fast enough through the emergency department to get onto our trauma ward, then I would get them there. So it's usually on that first day, which is why I have the time of their injury, like an estimated time of injury. I have that admission is as soon as I essentially hear about them and can get to them to draw the blood. And then I would do the blood draw, or we'd get one of our amazing research nurses or team to be able to get the blood. And then we would run it that day for the admission. And then we would do the next day as our post-fracture day 1. So that's kind of how that goes.
So I have some questions in terms of the procedures. So the bloods, are these this whole blood citrated?
Yes.
So how long, you mentioned that the blood may sit for how long?
So if the patient is in the ward, like let's just say they're on our trauma ward, unit 44, we go up, we take their blood. Now, as per our protocol, the blood has to be mixed and sit for 10 minutes at least. And because it's in that citrated. So we do our gentle 5 and it's sitting for 10 minutes, but really that's the time that it takes me to get from our unit 44, walk across to our University of Calgary campus at Foothills, get to our lab, pull out our cartridges in order to put them in the machines, get it running, and then be able to run it. So it's always ran within our manufacturer recommendations is 3 hours.
Does anybody know the variability in the time dependent. And the other question, I have concerns about TEG because one, the limitations in terms of controls, because you're really restricted in the number of samples you can do. My experience is not as good as yours in terms of reproducibility of study. So I would ask, okay, are there standardizations in terms of age? Because yes, it's 50 plus or minus 20. So that goes from 70 down to, that's a standard deviation. I don't know, but you're talking about a huge range in age, in sex, in time to doing this, using the machine, and in the duplicates and replicates. And you can't do duplicates and replicates with TEG, which is really my major concern in these studies. So do you ever do, say, day 1 and day 2 and day 14 and day 15 and day, right? So that at least you know days, rarely close times, does it change? And then finally, I'm on a roll here. I'm wondering about,
I don't know if I'm going to remember it all.
I'm wondering about controls. Because we don't have any controls in these studies, healthy controls.
For sure. So we don't have any healthy controls. For TEG, essentially, so I wouldn't say I'm an expert. Okay. I am ultimately a master's student. I am trying to become an expert.
Well, you're doing a great job.
Well, thank you. But they do have those ranges, and I know those ranges are large, which is the thing. And they give us this general range of what an MA value should be within for an average healthy person. But you're absolutely right. Ideally, what we would have is we'd have multiple patients so that we would be able to be like, hey, so I'll give you a great example. My population, for instance, pelvic and acetabular fractures kind of get separated into 2 groups. One, I have really young patients who are in motorbike accidents, car crashes, high impact sports, that sort of an accident. And then now with our aging population and osteoporosis, I'm having more individuals who are falling over, and instead of a hip fracture, they're getting an acetabular fracture. So it really is this bimodal population. And ideally, I would be able to separate those 2 and be able to look, hey, let's look at the young trauma patients separate to the older, more frail. And that's kind of why I have that age range too of plus or minus 21. And it does make it really tricky. And obviously this is 12 patients, so it's very tricky. And would I come to any major conclusions based off of this? No, but I think it's definitely interesting to see the general trend and that they're closer when I match them with age as best as I can, match them with BMI as well I did. And the age, the BMI, age and BMI, I did like t-tests to see if they were statistically significantly different, and they were not. So I did a good job with the matching, I guess. So that's good. So all the things that I'm trying my best to be able to see if we can see if it's worth continuing, essentially. But I'm hearing you with all the things, because it is complex and you need. Okay.
I'm going to Maha, you had a question. Are there any other student questions before I jump to Maha? And I sort of dominated that. Okay, Maha, a short question, and Ashley, a short answer.
Just quick questions. Those are some of the limitations, of course, of the TEG. And I think Ashley did a very good job tightening those things in matching. And I fully agree. There could be issues, but this is the best you could do. And we always avoid in terms of controls, we always avoid the manufacturer control and use the same patient. So this is the best basal level to compare to, or the tightly aged and sex matched. So that's just a comment. My quick question is on the translation of this. So am I understanding this correctly, that the idea is use TEG to determine the duration of thromboprophylaxis, and as long as the patient remain hypercoagulable, you will remain to give thromboprophylaxis?
So essentially
of the MA 65?
Yeah, so essentially, ideally, long in the future, we would be able to guide it, have more of a precision-based approach to thromboprophylaxis prescription, but just having some sort of guideline to be able to be like, hey, you're an orthopedic surgeon, you have this non-operative pelvic and acetabular fracture patient, what are you going to do? They worry about sending them home without anything for how long. So then if they had some sort of evidence to be able to be like 2 weeks, you can give them aspirin as per the study that I highlighted, it would be an option for these patients. It's just, it would be nice to be able to provide some sort of evidence for duration that they might
ideally an RCT if possible, and I know it's difficult with this question. Thank you.
Yeah, thank you so much.
Thanks, Ashley. That's great. Okay, we're still struggling to know how long to give patients with normal routine DVTs, PEs, anticoagulation. 45 years since I started training. So here we go. All right, new question. Next speaker, Veronica DeYoung, as a master's candidate, MSc candidate in McMaster under supervision of Dr. Colin Kretz, characterizing protease resistant Adams TS13 mutants. Fantastic. Okay, Veronica.
Thank you. Okay, share my screen.
Looks good.
Okay. I'm just minimizing you guys. Okay, so thanks for the introduction. I guess this has been done for me, so I'll get right into it. So my work investigates ADAM TS13 regulation, and just to save some time, I'm just going to say TS13. So to start off with a bit of context, TS13 is a circulating metalloprotease that regulates the length of von Willebrand factor, or VWF. And VWF is a multimeric glycoprotein that bridges platelets to the site of vessel injury, and longer multimers can bind more platelets. So having excess ultra-long multimers in circulation is a risk factor for thrombosis. And as we're continuing to learn, poorer outcomes in thromboinflammatory conditions like sepsis or stroke. So as a regulator of VWF, TS13 has shown promise as a treatment for numerous conditions in animal models without seeming to cause bleeding so far. So now I'll go over this interaction between them. VWF is the only known substrate of ADAM TS13, and its cleavage relies on multiple exocytes. So TS13 circulates in a closed conformation, which shields proximal domains that are necessary for cleavage. And when its C-terminal cub domains bind to VWF, this opens the conformation. Then with sufficient shear force, TS13's proximal exocytes can bind to unraveled VWF. And this aligns the bond within the active site so that cleavage can occur. And if you disrupt any of these exocytes I mentioned, it can reduce TS13 function in vivo. So TS13 is a unique enzyme because it evades common regulatory mechanisms. And while the shear dependent availability of VWF and the latent form help to localize its activity to where it's needed, it doesn't explain how TS13 activity is limited to allow for VWF mediated platelet capture, especially because the shear force required for cleavage and platelet capture is similar. And also without any other mechanisms, it could make TS13 possibly the only known blood protease without direct regulation. So identifying possible regulatory mechanisms could help us to optimize TS13 therapy. So one possible mechanism is proteolysis of TS13. And there's evidence of this in sepsis-induced DIC patients and also in a TTP patient with plasmin inhibitor deficiency. And TTP, in case you're unfamiliar, is a deadly microvascular thrombotic condition that is actually caused by TS13 deficiency. And when you add TS13 into acute phase plasma from this patient, it degrades, unlike in plasma obtained in remission. So this is due to increased plasmin activity, which likely contributes to this episode of TTP. When TS13 is degraded by factor 11A, thrombin, or plasmin, its capacity to cleave VWF platelet strings in a microfluidic flow assay is diminished. So these data support the importance of the C-terminal domains for docking to VWF under flow, and removing these domains reduces its antithrombotic capacity. While endogenous TS13 is not degraded in plasma when you initiate coagulation, plasmin activated by streptokinase or UPA can degrade endogenous TS13. And also, as you increase either TS13 or protease concentration, more cleavage occurs. So while systemic degradation of TS13 may not be very significant, this may not remain true at sites of vessel injury or in disease, where local protease concentrations could be higher. And also therapeutic TS13 is both costly and given in high doses. So if proteolysis does occur, preventing it might prolong or possibly enhance its efficacy. So our objective is to investigate the importance of this mechanism in vivo using protease-resistant mutants of ADAM TS13. And we found that these two flexible linker regions, which we call T4L and T8L, are cleaved most commonly and rapidly among various proteases. So we replace them with glycine-serine linkers, which maintains flexibility of the tail while capturing multiple cleavage sites. and prepared 4 mutants, 2 with one of each site mutated, a third with both sites mutated, and then a fourth with an additional elastase cleavage site mutation, which I'll talk about in a little bit. So the aims within this project are to validate the resistance of the mutants to cleavage in vitro, ensure the mutations don't affect their activity, and finally to compare the therapeutic efficacy of the double mutant to wild type in vivo. So I first looked at the mutants' resistance to purified coagulation proteases using Western blot, and I found that all proteases cleaved wild type at 2 distinct sites over 3 hours, as you can see with these 2 separate products. The T4L mutant is resistant at one of these sites, and the T8L mutant is resistant at the opposite site. And finally, the double mutant is nearly completely resistant to each protease over the course of 3 hours. I repeated these experiments with neutrophil proteases, and as you can see, there's more full length in the double mutant remaining at 30 minutes compared to wild type, but it's still fully degraded by 3 hours, so there are additional cleavage sites present. And we also found that mutating the elastase cleavage site conferred complete resistance over 3 hours to elastase. I then moved into plasma assays to better replicate physiological concentrations. So first I added wild type to plasma and initiated coagulation. And despite peak thrombin concentrations of around 200 nanomolar, minimal degradation occurred after 90 minutes. And I also repeated this with different tissue factor concentrations and it didn't change the result. So this suggests that thrombin and other coagulation factors may not significantly degrade TS13 when other substrates are present. I then did a similar experiment in the presence of TPA to see the effects of plasmin generation. And this time there was degradation of TS13 that increased with TPA concentration. So this suggests the importance of plasmin generation for this mechanism, which aligns with the prior evidence in that TTP patient that I mentioned. And when I repeated this with the double mutant, I found that it was fully resistant to degradation under maximal wild type degradation conditions. I also looked at the mutant's resistance to an increasing number of activated neutrophils, which are an important contributor to thromboinflammation. And as you can see, the double mutant is more resistant than wild type when incubated with 50,000 neutrophils, and the mutated elastase site confers even more resistance. But this last mutant is still fully degraded by 500,000 neutrophils, which may be attributable to the activity of proteinase 3 and cathepsin G. So finally, to start to compare the double mutant activity to wild type under flow, I used a microfluidics assay. And to summarize this method, I cultured endothelial cells in microchannels, then run stained platelets over them, and this will shear activate the cells and form VWF platelet strings that are visible under a microscope. So here's a snippet of the strings while running just buffer over them, if you can see that okay. And then this is in the presence of 5 nanomolar atom TS13. So you can see that the strings are being cleared more in the presence of TS13. And I've quantified this activity by plotting the total length of VWF strings as a percent of baseline over time. And so far the results align with prior studies. MDTCS or TS13 without C-terminal domains is less effective than wild type under flow. And so far the double mutant seems to have similar activity to wild type, but this does need to be repeated, so it's a work in progress. So overall, the mutant's resistance in vitro has been investigated, and I'm now continuing to study the activity of the double mutant, which needs to be completed before moving on to any mouse models. So I just want to acknowledge my lab members and other labs throughout TARI who have been really helpful, as well as my committee members and funding. Thank you so much.
So questions? Paul, do you have a question there?
Patricia has a hand up.
Patricia, where are you? Oh, I'm not looking that high. Cool. Okay, sorry, Patricia, go for it.
Great talk, Veronica.
Thank
I
you.
just have a question on the use of IW13 as a therapy. So is that given at doses that are much higher than physiological levels?
So it's given, so right now the dosage that's in clinical trials to treat TTP, the maximum dosage is 40 units per kilogram. And when they give that to congenital TTP patients who have very small amounts of atom TS13 to begin with, it brings it to about a normal circulating concentration of about 5 nanomolar. But the dosage of 40 units is much higher than 1 unit per mil that is a normal level. But when you look at other conditions in mouse models, at least, so for example, in sepsis or in stroke, it's given at about 3,500 units per kilogram in mice, but it hasn't really been investigated at the smaller dosages that are given to humans. So it's not exactly clear if those doses that have therapeutic efficacy in mice for these conditions could be reduced. So it definitely requires further investigation.
All right, thank you.
Other questions? So are there analogous sort of systems that have the same situation in terms of the enzyme and the lack of a specific inhibitor? Are you familiar with any?
I'm not really aware of any that don't have any direct means of regulation. I'm not 100% sure about any that don't have an inhibitor at all. But yeah, I do think that the combination of being stable and having a really long half-life, not like being resistant to inhibitors, even inhibitors that inhibit other ADAMTS enzymes, I think is pretty unique in the case of ADAMTS13.
You mentioned experiments with neutrophils. Are those forming nets?
I haven't looked at that. I actually just did that experiment. All I did was I incubated a certain number of activated neutrophils in a test tube with ADAMTS13 and just did a Western blot of the ADAMTS13 afterwards. So I'm not sure if they're making nets or not.
So is the regulation then maybe just really reliant on the modifications or changes in von Willebrand factor, the target?
It could be. The thing that is kind of strange to me is that when you unravel VWF to capture platelets, ADAMTS13 is also capable of cleaving it. So it could just be a matter of stoichiometry. Maybe there's just a lot less ADAMTS13 than there is VWF, but it's hard to say because when you have high doses of ADAMTS13, at least in animal models, it doesn't seem to cause bleeding. So yeah, I do think it's something interesting to keep looking into.
Keeps you busy.
Yeah.
Cool. Any other questions or comments? No. Cool. Great work. Challenging too. Excellent. Thanks, Veronica. Okay, last but not least, before the last but not least, is Nicole Morris, Master of Science candidate at Queen's University, supervised by Dr. Kirsten DeWitt, a pilot study to assess feasibility of evaluating the safety and efficiency of a simplified diagnostic approach for PE. How's that? Nicole.
Thank you.
Yeah, really, you couldn't have picked a longer title. All right, Nicole, you're up.
Okay. Can everyone see my screen?
Perfect.
Okay. So thanks for the introduction. I will just get right into it. First and foremost, as I'm sure everyone here knows, pulmonary embolism, or PE, is simply the medical term we use to describe blood clots in the lungs. So moving on to how PE is diagnosed. In Canada, many of these diagnoses take place in the emergency department and involve the use of advanced diagnostic imaging, such as CT or VQ scans. But with this being said, diagnosing PE in the emergency department is often extremely challenging for emergency physicians. And this is because its symptoms are nonspecific and they overlap with many other conditions. So to try and address these challenges, a number of what we call clinical decision rules have been designed to standardize PE testing and try and reduce unnecessary advanced diagnostic imaging. And most of these rules combine the use of some sort of clinical score or checklist with the blood D-dimer. And in case you don't know, the blood D-dimer is just a biomarker of the blood clotting process in the body, and it's obtained through a blood test. So these all sound great, but unfortunately, what our research team has found is that in practice, emergency physicians actually don't like and don't use these existing clinical decision rules. And some of the reasons we've identified that they're not using these rules include the fact that they find them to be too complicated and complex and time-consuming in the emergency department. And additionally, what many emergency physicians have told us is that rather than apply one of these rules, they prefer to use their own clinical judgment to determine whether or not a CT scan should be ordered for their patient. But this is extremely problematic because research shows that implicit judgment overestimates the probability of PE. And if we're overestimating the probability of PE, then we're fueling the overuse of CT scans. And in Canada, we have a look at the numbers. We can see that PE is only being diagnosed in 8% of emergency patients who are tested for it. So what do we do? To try and solve this problem, we've developed a new diagnostic algorithm that is simple, fast to use, and it incorporates an element of implicit determination, which we've learned emergency providers prefer. We call it adjust unlikely, and to use the algorithm, all physicians have to do is order a D-dimer and then answer one simple question. In their opinion, is PE the most likely diagnosis? And if it is the most likely diagnosis, then it can be safely excluded in patients who have a D-dimer of less than 500 without needing advanced diagnostic imaging. And on the other hand, if PE is not the most likely diagnosis, then it can be excluded in patients who have a D-dimer less than the age-adjusted threshold. So now I know what you're all thinking. This sounds great, but does it actually work? Is it safe? And to date, our understanding of the diagnostic algorithm is limited to just one diagnostic accuracy study. But here the results were found to be promising, as the rule was found to be 100% sensitive, and it would have reduced the need for CT scans by 32.4%. So it's our ultimate goal to be able to assess the safety and efficiency of the algorithm in a large multi-site study across Canada. But before we can scale up, we need to ensure that such a study is actually feasible, which brings us to the aim of my research, which is a pilot study with the aim of assessing the feasibility of a future larger study. And we're hypothesizing that we can recruit at least 20 patients per month who were tested with adjust unlikely in the emergency department, and then follow at least 90% of patients for 90 days to determine if they had any additional blood clot testing or diagnoses taking place. And we have a target sample size of 200, which should be sufficient to establish recruitment and loss to follow-up rates. So now I can get into my study's methodology. This is a prospective management pilot study enrolling patients with suspected PE who are tested for it in the emergency department at Kingston General Hospital or our urgent care center at Hotel Dieu Hospital. And that's, so if they're tested that way, then they're eligible for inclusion. And you might be wondering how exactly we're going to ensure providers are actually following the algorithm. So what we did prior to study launch was work with our IT department to program the adjust unlikely items directly into our electronic medical record. So now if an emergency physician goes to order a D-dimer, they're required to indicate the reason for the order. And if they select PE, then they're prompted to follow adjust unlikely. In terms of how I'm collecting data for my study, following emergency department discharge, I'm calling participants who are eligible for inclusion because they were tested with adjust unlikely, and I ask for their consent to review their hospital records over the next 3 months to check for any additional venous thromboembolism events. And additionally, I will also follow up with each patient at the 90-day mark. In terms of study outcomes, the pilot study has 5 main ones. I've kind of already talked about the first 2, which is to establish a recruitment and loss to follow-up rate. We're also hoping to make a comparison of excluded and missed eligible patients to study participants. So comparing things like age, sex, and prevalence of PE on initial assessment. And finally, although my sample size of 200 won't have the statistical power to determine the safety or efficiency of the algorithm, we will be able to estimate them. In terms of preliminary results, there's not a whole lot to report just yet because participant recruitment actually only started a few weeks ago. But to date, I've gone through the first week of D-dimer orders that took place in the emergency department and urgent care center. And there were about 100, and within this 100, 83 were for suspected PE. And when we further narrowed it down, 57 of these patients were eligible for inclusion in the study. And I've been able to consent 26 of them, so just below half so far. We're working away at our second week of D-dimer orders now, and to date in the study, we've consented 35 patients. And so far, out of these 35 patients, only one was actually diagnosed with PE during their initial assessment. Finally, in terms of translational impact, adjust unlikely is the only PE testing rule that's been designed specifically to align with the emergency department environment and physician needs. We're hoping to show that a full study is feasible and leverage our results to conduct the study over multiple sites across Canada. And ultimately, the adoption of adjust unlikely by emergency departments across Canada could result in standardized practice, fewer CT scans, shorter patient visits, and improved patient care. And finally, just thank you to my supervisor, my supervisory committee, and CanVector.
Well, thank you. Questions? Ashley.
Yeah, I do have a couple questions, kind of question comment situation. So first off, what is your electronic medical system that you guys use? Because you're in Ontario.
So in our emergency department, we use EDIS, it's the electronic department information system, but it does vary depending on where you are. That's just the one we use. And then so that's just specific to the emergency department, but for the rest of the hospital, we use what's called PCS. So there's already kind of 2 EMRs in Kingston at the moment.
Okay, cool. Good to know. Just curious because we're in the process. Well, we've now transferred over from our old system to our new system. So I was just trying to think about feasibility because that must have been hard to implement as well from an IT perspective.
Well, what's actually really disappointing. So Dr. DeWitt had this order in for about a year before it actually got implemented. But all of our regions, so not just Kingston, but the surrounding areas in Southeastern Ontario, next year, we're all actually switching to Cerner, which is an entirely new system, which it's going to be really complicated.
But the good news is if this can work, then we'll figure it out on different systems. So then my next question, I guess, is, are you aware of feasibility of D-dimer with surgical patients?
No.
Okay. So just from at our site and what I've learned in the orthopedic trauma world is that often D-dimer, yes, is ordered, but often surgeons don't even order it. I don't know if the emerge docs necessarily do. So it might be worth looking into a little further because they're almost always elevated in surgical patients. So it's just something to know, because maybe, I don't know, maybe an emerge doc would be like, oh, I don't need D-dimer because they just had surgery a week ago. I'll just send them for. So maybe there's a potential to be missing, but I'm not sure. I just want to put it out there.
It's this is more for categorizing low to moderate risk blood clot patients. Because there are some risk factors that we know predispose an individual to developing a clot. And you're right, in terms of feasibility, we're completely missing anyone that goes for a CT or VQ scan that didn't have a D-dimer ordered. So if a patient comes in and they're super high risk and the physician just sends them for the scan, then we're missing them. So yeah, it's definitely something to keep in mind.
Great, thanks.
Other questions? So you're drumming out the responsibility of the physician. It's cool. By taking away decision-making really, you're directing them with appropriate guidelines, but I think it's obviously important. I'm being facetious. These are things that are overlooked. But to Ashley's point, I mean, it's only valuable if it's low. If it's elevated, it's not specific. And that's really the point, though. And the emergency department is a good place for that. Surgeons probably should be using it more, because if it is low, it excludes pretty well any kind of venous thromboembolic phenomenon, and that would save a lot of money. Doing a D-dimer is a lot less expensive, certainly, and invasive. Other questions, comments? Nothing. Fantastic.
In the chat there, Ed.
Oh, so somebody?
Dr. Oatman has a comment and a small question.
Okay, there are various D-dimer assays and different unit reporting. Do you know if all the patients are done in the same way?
So at our sites, it's a standard assay, but that would be another issue that we've talked about in terms of feasibility. Like, you definitely couldn't do this study using a bunch of different assays with different manufacturer recommended cutoffs. It would just completely bias the results. So it's another thing to keep in mind if we actually want to scale this up.
Good point. Okay. All right, I'm going to hand the mic over to Paul.
Thanks, Ed. Do we want to have a little quick bio break, like 5 minutes?
Oh, that's not a bad idea. Okay, why don't we do that? 5 minutes, but please come back for a fantastic presentation, as also the awards and pictures. I don't want to forget, we need to get a picture of everybody together, at least. Certainly the trainees and pictures. Okay, 5 minutes. 11:23, we'll be back.
Very good. Patricia, do you want to try testing your setup there?
Yeah, so I switched over to my other computer. Does this sound better?
Much better.
Yeah. Okay, great. Okay. I guess we're good to go in 5 minutes?
Yep.
Thanks.
See you shortly.
Paul, is it okay if I have my screen shared just to get things ready?
Yeah, I think Caleb could help us out.
Yep. Yep, I just turned mine off.
Did somebody take a note of the time when we're supposed to start? I forgot to take a look. You're muted there, Ed.
Yeah, no, 1 minute ago.
1 minute ago. Okay.
Ago. Is everybody here? I want faces, faces, faces. Ashley, Lisa, Maha, Nicole, Kendra. Oh, we got them all. Coming. Okay. Just
All right.
we don't know if you're really there. Now we know we're there.
Okay, so let's get started if that's all right. So welcome back from our little break there. It's a great pleasure and honor to be introducing our keynote speaker, Dr. Patricia Liao. She's a professor in the Department of Medicine. She also works 4 doors down from me here. She's in the Department of Medicine, Division of Hematology and Thromboembolism at McMaster. Her research program focuses on understanding the biological links between infection, innate immunity, and blood clotting. Since 2018, she's been the chair of the Canadian Critical Care Translational Biology Group, a national network that promotes translational research in critical care medicine. And she is also the inaugural recipient of the Jack Kirsch and Clive Kieran Endowed Chair in Thrombosis at MAC here. So without further ado, please, Dr. Liao, welcome.
Thank you very much, Paul, for the kind introduction. I'd just like to thank Dr. Kim, Dr. Conway, and Kim Vector again for the opportunity to present at the Basic Science Symposium. If there's any issues with my audio, please let me know. So my presentation is called Immunothrombosis Research from Bench to Bedside and Back. So as we heard earlier in Ashley's presentation, Virchow's triad of thrombosis predicts that there are 3 main factors that contribute to the development of thrombosis. The first is stasis, which may be related to prolonged immobilization or limb paralysis. There's also a vessel wall injury that could be related to trauma, surgery, or the use of indwelling catheters. And then the third major factor is a hypercoagulant state, which may be genetic in nature, for example, acquired deficiency in natural anticoagulants, or acquired hypercoagulability due to conditions such as pregnancy. So over the past decade, there's been a vast amount of data that indicates that there's a significant fourth player in thrombosis, and this can be termed immune dysregulation. In particular, there are innate immune cells that contribute to the initiation as well as the progression of thrombosis, and this is a process termed immunothrombosis. So which cells participate in this process? There are circulating monocytes, which under conditions of inflammation or infection will upregulate the expression of tissue factor, which is a potent trigger of blood coagulation. They can also secrete pro-inflammatory cytokines, and that will lead to increased adhesion of leukocytes to the surface of endothelial cells. When neutrophils are activated, they can release neutrophil extracellular traps that not only trap red blood cells and platelets, but they can activate blood coagulation through the intrinsic pathway. They can impair fibrinolysis, and components of these nets, such as histones, are extremely cytotoxic. Platelets contribute to the formation of the platelet plug. They also amplify coagulation, and they can induce the formation of nets. And then finally, endothelial cells, through expression of VWF, which we heard in Veronica's presentation, is responsible for platelet adhesion. Endothelial cells can also upregulate P-selectin, which contributes to the adhesion of leukocytes. And by releasing PI1, it inhibits fibrinolysis. Importantly, endothelial cells under physiological conditions promote an anticoagulant environment through the expression of thrombomodulin and EPCR. And in conditions of inflammation and infection, these receptors could be shed. So we take a look at clots from patients with pulmonary embolism. You can see that the clots contain fibrin and platelets, but also monocytes, neutrophils. And then here on the right panel, you can see that there is diffuse staining for extracellular DNA, which is released mainly by activated neutrophils in the process of mitosis. So I just want to share my journey in the research in the crosstalk between the pathways of blood clotting and immune activation. And I think this really started around the time that I was looking around for places to do my postdoctoral training. I was interested in labs that had expertise in the biology of vascular endothelial cells. So when I was finishing up my PhD in Dr. Jeff Weitz's lab, where I was looking at structure function relationships between coagulation factors and their inhibitors, I decided after interviewing at several places that I wanted to join the lab of Dr. Chuck Esmond at the Howard Hughes Medical Institute at the Oklahoma Medical Research Foundation. And I don't think I really knew how far away that would be, because I said to my husband at the time, who was finishing up his PhD, I said, no problem, I can drive back every weekend for a visit. But as you can see here on the map, Oklahoma City is about 2,000 kilometers away from Hamilton. So in the end, I ended up flying back every 3 weeks and racked up a lot of air miles. So the entry to the US was a bit complicated. First, my Ford Taurus was packed with everything that I needed to start my fellowship. And I also brought my hockey skates because it was around the time that I was learning how to play hockey. In retrospect, it really didn't make any sense to bring skates to Oklahoma, given that there really aren't any ice rinks there. But my initial entry as a postdoctoral fellow was denied. And the reason was because there are only a limited number of professions as per the US Customs. So my employment letter, which said postdoctoral fellow, didn't actually match any of the other professions, such as police officer, pretzel cooker, potato chip fryer, parachute inspector. So I had to get my mentor, Dr. Esmond, to rewrite the employment letter and indicate that I would be a biochemist. And that was helpful in letting me clear the customs. So my first week as a postdoctoral fellow, I was excited to start learning about the biology of the vascular endothelium. And then I realized that we actually didn't have access to the proteins that we wanted to study. So the two proteins that we were studying were thrombomodulin and endothelial protein C receptor. This is just an image from my lab book where you sort of had to come up with protocols on the fly. And in this case, we were using leftover human placenta from the maternity wards as a source of endothelial cells. And you can see here in my lab book, I said that I obtained 2 human placentas from the P1 parking level. I guess that's where we had the freezer to keep these extra placentas. And it was a pretty crude extraction method, starting off with blending the tissue and then followed by various column chromatography procedures, and finally using monoclonal antibodies to extract some of these proteins that we were interested in studying. So it was really at that point in my research career where we were starting to understand how the protein C pathway, which Sean had described in his presentation, how it's important in preventing blood clotting within the microvasculature. So there are many receptors that are involved in this pathway, and under conditions of systemic inflammation, you can get shedding of the receptors, and that results in microvascular thrombosis, such as what is seen during skin necrosis. So this was part of the reason that as a postdoctoral fellow, we were interested in the links between blood clotting, vascular endothelial dysfunction, and microvascular thrombosis. And this was in the context of sepsis, which is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. It is a heterogeneous life-threatening disease. There are many different sites of infection, such as the lung, the blood, the urinary tract, the skin, and also different types of infection, including bacteria and viruses. It's the leading cause of death in the ICU and worldwide, with mortality rates as high as 50% in individuals, at a cost of over $1.7 billion annually to Canadians. So over the past decade, my research program has been focused on identifying some common mechanisms of infection-induced immunothrombosis. So in this diagram, you can see that upon infection, and I'm using bacteria as an example, the circulating monocytes will upregulate tissue factor, which will initiate the extrinsic pathway of coagulation. Envelope viruses, including the SARS-CoV-2 virus, can also upregulate tissue factor on endothelial cells as well as circulating monocytes. The activated monocytes will upregulate inflammatory cytokines, which will cause systemic endothelial injury, leading to the release of ultra-large von Willebrand factor, release of Pi-1, which inhibits fibrinolysis, and shedding of thrombomodulin, which impairs the protein C pathway. The activated platelets will not only amplify coagulation, but they will also induce the release of neutrophil extracellular traps, which consists of neutrophil enzymes, as well as chromatin consisting of DNA and histones. And finally, the clots that are formed, as you can see depicted here, contain not only platelets and fibrin, but also red blood cells and activated monocytes and neutrophils. So in terms of translational research and why it's important, it provides a bidirectional link between the discoveries that we make in the lab and their application for the benefit of patients. And this is often referred to as bench to bedside, as well as bedside to bench research. And I just wanted to give an example of bench to bedside translational research that we've been doing in the field of immunothrombosis. So going back to that complex diagram where we showed that there is extensive crosstalk between infection, coagulation, platelet activation, and participation of immune cells. We had been studying an enzyme called recombinant DNase 1, which is a naturally occurring enzyme that has the ability to digest away the phosphate backbone of DNA. Given that extracellular DNA is a major component of clots that are produced in response to infections, we hypothesized that administering this enzyme intravenously might be an effective strategy to reduce the clots that are forming in response to severe infections. So we've used animal models. We've had two papers that have been published using the cecal ligation and puncture model. This is a little bit different from the FIT model that Sean had described earlier, in that rather than injecting fecal slurry, we're actually perforating the bowels of the healthy mice. And because there's a slow release of fecal contents, we can have a more long-lasting chronic model of sepsis. And we found that if we inject this enzyme intraperitoneally, it improves organ damage and also improves survival in the septic mice. In parallel with the animal studies, we were interested in measuring the levels of this enzyme in ICU patients with sepsis. And what we found is that in healthy individuals which have levels of around 40 microgram per mil, there is acquired deficiency of endogenous DNase 1 in ICU patients with sepsis. So this provides additional rationale for the use of this therapy in the treatment of the condition. In addition, we also looked at the levels of circulating DNA in critically ill patients with sepsis, and we found that the patients at the higher risk of death are those with much higher levels of circulating DNA, and it's approximately 4 to 5-fold higher than in healthy individuals. So we've recently started a phase 1 safety and feasibility study that is funded by CIHR. This is in collaboration with Dr. Alison Fox-Robichaud, as well as our colleagues in Montreal. And this project is managed by Dr. Marcelo Zapata, who is a critical care fellow with Dr. Fox-Robichaud. So we're looking to see if injection of recombinant DNase 1 into patients with sepsis would be safe and whether or not it's feasible. So we're proposing to administer it in 50 ml saline mini bags. And we propose a low dose of 25 microgram per kilogram twice daily for either 3 days or 7 days, and a higher dose at 125 microgram per kilogram for 3 days or 5 days. For each dose and each duration, there will be 6 patients recruited. And after the recruitment of the patients, there's a data safety monitoring committee that will assess whether this infusion is associated with any adverse effects before we can proceed to the next dose and the next length of duration. So I also want to give an example of bedside back-to-bench translational research. And we can use as an example the COVID-19 literature, which shows that giving therapeutic dose heparin appears to be beneficial in moderately ill patients, but not critically ill patients with COVID-19 related sepsis. And there were 3 large randomized controlled trials that were conducted in either hospitalized patients or patients that were treated in the ICU. So we started to think about revisiting heparin as a potential therapy for sepsis. Although it was first developed as an anticoagulant, and it does so by inhibiting by accelerating the inhibition of certain coagulation enzymes by antithrombin, heparin is also an anti-inflammatory molecule. And more recently, we've shown that it has the ability to inhibit histones, which are very toxic. So going back to the neutrophil extracellular traps, the DNA that is the major structural component of the traps can activate blood coagulation through factor 12A activation. But the most abundant proteins are actually histones. In addition to activating platelets, they're cytotoxic to endothelial cells, and they can also induce tissue factor expression on monocytes. We also found that the addition of heparin to recombinant DNase 1 actually enhances the degradation of neutrophil extracellular traps. So our hypothesis is that the time of administration of heparin likely impacts its effects on the host response to sepsis. And given that sepsis is a clinical state that falls along a continuum of pathophysiological severity, so the initial infection could be cleared, which results in the resolution of inflammation. But if the infection is disseminated systemically, that could lead to sepsis followed by septic shock, multiple organ disease, and finally death. We hypothesize that administering heparin early may be effective, whereas administration of heparin later in the progression of sepsis might be ineffective. We're also curious as to whether or not very early administration might have a harmful effects. And this is related to the fact that fibrin clots themselves can actually play a role in trapping and limiting the dissemination of microbial infections. So as part of the National Preclinical Sepsis Platform, which was formed a few years ago, this is under the leadership of Dr. Manoj Lalu, Asher Mendelson, Braden McDonald, and is one of the research pillars of Sepsis Canada under the directorship of Dr. Alison Fox-Robichaud. The National Preclinical Sepsis Platform, or NPSP, is a multi-center infrastructure that will allow us to rigorously study the pathophysiology of sepsis and to accelerate the movement of promising therapies into early phase clinical trials. So we compare preclinical research with clinical research. There are many limitations of using preclinical research models. First is that most of the studies are conducted in single centers. They're not randomized or blinded. Rarely are sample size calculations performed. And there's often variations in the protocol, which makes the results difficult to reproduce between different labs. In contrast, clinical research is often multi-center in nature. There's randomization and blinding. It's adequately powered. The protocols are standardized and shared, which allows the information and data to be synthesized much easier. So as part of the preclinical sepsis platform, we decided that a useful model would be abdominal sepsis that is induced upon the injection of rat fecal slurry. And this was described in Sean's presentation. The reason we decided not to use the cecal ligation and puncture model is that that model involves complicated surgical techniques, which would result in increase in variability between operators. The other advantage of using the fecal slurry model is that we can produce a large quantity of the rat fecal slurry that is frozen down into aliquots. And then this can be shipped to different centers so that we can standardize the pathogen that is used to induce sepsis. So using this model, we will look at 72 hours as our study endpoint. And this is useful for assessing overall mortality. At the same time, we can harvest the organs. We can spin down the blood to collect the plasma. We can also plate the blood and the peritoneal cavity fluid to quantify bacterial loads. So the advantage of this model is that we know exactly when sepsis will be induced, because that is the time that the fecal slurry is injected. And so we can ask the question, is there an optimal time frame to administer heparin? Just want to show some very preliminary pilot data that we have recently conducted to show that giving therapeutic dose heparin immediately after the injection of the rat fecal slurry appears to be harmful. And one possibility is that fibrin clot formation may actually serve a protective role during the initial phases of bacterial infection, as mentioned earlier, by trapping pathogens and limiting their dissemination. So just wanted to highlight that the time of administration of therapy does seem to impact whether or not the therapy is harmful or protective. The second hypothesis we had is that the protective effects of heparin is probably size dependent and independent of its anticoagulant properties, which are characterized by the antithrombin binding pentasaccharide. So in fact, 70% of heparin molecules actually do not contain the antithrombin binding pentasaccharide, and this is termed non-anticoagulant heparin. And as we heard earlier, heparin is a multifunctional molecule. It does have anticoagulant activities, but it also inhibits inflammation, and it's also cytoprotective. In vitro studies that Neha Sharma in our lab has performed, she was looking at the ability of 4 different types of heparin variants to inhibit some of the harmful effects of histones. So she looked at unfractionated heparin, as well as deltaparin, which is a low molecular weight heparin, vasoflux, which is a chemically modified low molecular weight heparin that no longer retains the antithrombin binding pentasaccharide. And then fondaparinux, which is an ultra small heparin, is a molecule that has anticoagulant properties due to the pentasaccharide. And what was interesting is that all of the molecules, except for fondaparinux, were effective as inhibitors of histones, suggesting that the ability of heparin to neutralize histones is related to the length of the heparin molecule, but not the anticoagulant pentasaccharide. So this can also, using the fecal-induced peritonitis model, we can also explore whether which of the 4 heparin variants will improve survival in response to abdominal sepsis. And this is also preliminary data where we found that unfractionated heparin, as well as non-anticoagulant heparin, can improve survival in septic mice. So this further supports what we found in vitro, in that the protective effects of the molecules seem to be related to its length rather than its ability to inhibit coagulation. And then the final few slides, I just want to share some thoughts about the treatment of sepsis and whether or not one size will fit all, given that it's a heterogeneous disease state. So as I mentioned earlier, there are different sites of infection, there are different types of microorganisms. And we found in a multi-center study called the Dynamic study that there are mortality risk profiles that we can generate for individual septic patients. So this was a prospective observational study involving 9 ICUs across Canada, where we recruited almost 400 sepsis patients. And we were able to collect extensive clinical data and also perform biosampling for the duration of the patient's stay within the ICU. What we found was that there are 6 major factors that seem to contribute to increased mortality risk. Some of these factors are clinical parameters such as platelet counts, lactate, creatinine, or Glasgow Coma Score. But we also found that high levels of circulating DNA and also low levels of protein C also contributes to poor outcome. And this suggests that there may be opportunities for a targeted approach where, depending on the mortality risk profiles, we can administer therapies that are tailored to the defects that the patients exhibit. For example, using DNase 1 therapy for those patients with very high levels of circulating DNA, or using heparin therapy for patients with very low protein C levels who lose their endogenous anticoagulant capacities. And then in my final slide, just want to give an overview of the prognostic and predictive enrichment strategies used in the treatment of sepsis. So using the indicators that we had identified, we can fill a knowledge gap in terms of prognostic enrichment. In addition, we can also enrich the, we can use predictive enrichment based on the biological pathways that seem to be impaired. This in turn can translate to a targeted approach for the treating of this heterogeneous population. So just want to summarize some of the strategies that we have been considering to overcome challenges in sepsis research. We're looking at new interventions, and that includes recombinant DNase 1 as well as heparin. And these studies will be done in a multi-center format. We're also looking at the timing and the dose of the therapies to identify the optimal duration and the time of administration. And then finally, using the translational data that we've generated with the multi-center observational studies, we can have a targeted approach using prognostic and predictive enrichment. And then finally wanted to thank the past and present members of my lab, members of the Canadian Critical Care Translational Biology Group, the National Preclinical Sepsis Platform, as well as Sepsis Canada, and our collaborators in Montreal and McGill, who will be conducting the phase 1 safety study of recombinant DNase 1 in ICU patients with sepsis. And that's the end of my presentation.
Thank you, Patricia. That was a great presentation. And it's, I want to invite all the trainees to ask questions to Dr. Liao, because what we're hoping to sort of provide is a unique opportunity in which you can engage, renowned scientists such as Dr. Liao in a more personal level than a typical formal presentation that you would see at a conference, and in particular discussing her career path. I mean, it's fantastic, and I can't tell if I'm more impressed by the fact that you have access to your lab book still, or that you can actually read your lab book. Your handwriting is phenomenal. I don't think I've seen it before.
Well, I don't know if you can see the back of me, but this entire shelf here, those are my lab books from my postdoctoral fellowship. And I was there for exactly 24 months, and I've got 24 lab books. So I guess it was about 1 lab book per month. But thank you, Paul.
Yeah, I have lab books too, but I can't read anything in there. So they're just as good for nothing. Okay, do we have any questions? Few quick questions from trainees? Burning questions about science or personal pathway to where she's ended up? What would you say if, while people are possibly coming up with questions, I'll just throw this out there. What would you say that the biggest challenge was? Because obviously for, including myself, deciding to pick up everything and moving somewhere else, that it's a big commitment and it's a huge change. And, even coming from Kingston to Hamilton, to me, that was a big commitment, let alone going to Oklahoma and committing to travel and driving 2,000 plus kilometers every weekend. That's incredible. So what would you say was the hardest part? And you know, how did you decide in Oklahoma as the place to be, aside from the science, obviously?
I think the hardest part was trying to explain why I'm doing this to my Eastern European mother-in-law. That was quite a challenge, but I think it helped that Steve, my husband, was also in academia. So he was doing his PhD at the same time, and he ended up going to Harvard at Children's Hospital. So what I didn't share in my presentation is that not only was I in Oklahoma by myself, but then when I came back to McMaster, Steve was in Harvard doing his postdoctoral training. We made it work by frequent phone calls and flying, you know, to visit each other every few weeks. But, you know, I think I wanted to go where the science and the mentorship would be the most impactful. And even though I interviewed at industrial positions such as Eli Lilly in Indianapolis, I was just really impressed at the facilities in Oklahoma and just the amount of research support and the fresh ideas that were coming out at that time. Also, ignorance is bliss. I say this all the time. I try not to think about things too much because then I'll just talk myself out of everything and I won't end up doing anything at all. So does that answer your question?
Absolutely. No, that was great. It's always nice, always interesting to see insights and how people make their decisions at the end of the day. Are there any questions for Dr. Liao from trainees? Yeah, go ahead, Ashley.
Mine's not really a question. I just wanted to say thank you for the talk, and that's very inspiring and a little intimidating for us, but it's something to aspire to. And I was just wondering if you could tell us a little bit more about like earlier days, like masters, like most of us are, or did you do your master's and then a PhD, or did you do a transfer, or what did that look like for you? And how did you know inside in your soul that academia was the path?
I think I took a long and winding path. So my undergrad was in biochemistry at McMaster University. And I did my master's also in biochemistry at the University of Western Ontario. We were studying eukaryotic regulation in using the baker's yeast as a model system. So the lab constantly smelled of freshly baked bread, which is great. That was before the days where everything was available in kits. So all of the methylation interference analysis, DNA sequencing, protein purification, it was all done from scratch. I learned a lot in terms of enzymology and protein biochemistry, but I couldn't really see the relevance of what I was doing and how that might be applied. So I actually took a year off after my master's, worked as a research assistant. And then just by chance, I met Dr. Jeff Weitz, and he was just, I think he was just starting up his research program in the biochemistry of blood coagulation, fibrinolysis. That was a very rewarding experience, a great lab environment, great lab culture. And from there, I continued on to my postdoctoral fellowship and then came back at McMaster, to McMaster.
Thank you for sharing that with all of us. I think that gives a little bit of, you know, perspective for me, at least, who's coming to the end of the whole master's route and trying to figure out next steps, or if this is like, I'm very much in that orthopedic trauma world, trying to branch out, see if there's something that like really is, this is going to be my future. So I appreciate you telling us your story.
Okay, there's no other questions. I think we'll move on to the prize portion. I don't know if we have a script for this, other than to say that I think CanVector has decided to award two presentations today. And I think Caleb can sort of let us know what the results are.
Yes, for sure. Thanks everyone for submitting votes, and all the presentations were great. And then, so the runner-up, the number 2 ranked presentation was Ashley Clark, and the number 1 is Lisa Yamura, who's I think she had to step out. Yeah.
Okay, congratulations. Thank you very much. I don't want to say what it is because I can't really remember what the prizes are, but we will reach out to you directly.
Yeah, we'll be sending gift prizes and reaching out offline.
Okay, very good. I think that's, yeah, go ahead, Patricia.
It's not a brand new car.
No,
I think we are not communicating properly as to the magnitude of the prize here, but
it's a one-way ticket to Oklahoma.
Whoever goes, if they
right.
bring my skates back, because I left my skates there.
Oh, by the way, I don't think you could have passed as a plumber as your employment because plumbers make good money. All right, well, thank you everybody for joining today, and it really is nice to see, you know, all the trainees and that CamVector has supported and involved with, and the you know, the fruits of your labor, and we get to see a little glimpse of your hard work and of course interesting science that also helps. And you know, and there are names here who will likely, you know, join in future CamVector members and moving forward. And you know, we look forward to seeing your results in publications and other conferences. And with that, unless you have something else.
Hold on, pictures.
Oh,
Caleb, right. I knew it. You always forget. We always forget. Caleb, can you do that?
Yes, I'm gonna screenshot it. So anyway, I have videos only on my screen, so I can take it. So
okay.
When that, okay, so let's yeah, perfect. Okay. So I'll give you like a little countdown so you can smile. Okay, so 3, 2, 1. We're good. Okay, I'll do one more. Okay, 3, 2, 1. Good. Okay, I got 2.
Got it.
Perfect.
Thanks everyone on my as well, and it was fantastic. I really enjoyed it.
And hope to see many of you in Montreal for ISTH.
Absolutely.
Yeah, it'll be fun.
Good.
Okay, thanks everybody.
Good work
thanks,
and enjoy.
Thanks, Patricia.
Bye.
Thank you.